Okay, let's talk about how to treat some of the dysrhythmias. So we now learned how to read the EKG strip, what kind of rhythms are lethal, which ones we might have more time on. So let's talk about each one. This is just a repeat of the previous one. So how's the patient tolerating it? Is it lethal? How are we going to treat it? What kind of symptoms do they have? So different kinds of medications that we are going to give patients. You're currently, I believe, in the pharmacology class. We're going to review a lot of these medications because they're coming up in clinical and they're coming up now for this lecture. So just bear with me with some of the medications and we'll talk more about them. So there's certain medications that help dysrhythmias, calcium channel blockers, beta blockers. Some of these are IV, they can be PO. We can do synchronized cardioversion, or we can do defibrillation. So cardioversion and defibrillation, that's when you're actually putting pads on the patient and we're going to shock them. We could take a patient to the EP lab. This is electrophysiology lab, and we can kill the cells in the heart that are causing the problem. So we can find the cells that are causing the atrial flutter or causing the atrial fibrillation. We can kill those cells and hopefully the patient will not have AFib or an A-flutter again. We can put in pacemakers. Pacemakers are a great way to fix the heart if they're in third-degree block or second-degree block type 2. If a patient's going to keep coding, we can put in an implantable cardio defibrillator, converter, or defibrillator. So an implantable ICD. So for sinus brady, we know it's below 60 beats per minute. Obviously, number one is we check the patient. Can the patient tolerate that? Are they having any symptoms? If you're not getting enough blood flow to your brain, which is is the first artery off of your aorta, your brain gets first pick at your newly oxygenated blood. If you're dizzy, you're confused, you are sweating, you're diaphoretic, you feel faint, obviously a sinus brady is not giving you enough perfusion. So check the patient. If we need to do something right now, we can give IV atropine. IV atropine will increase the heart rate, and that will buy us some time on what to do. So give that IV atropine if we need to, if we have it. We can put an external pacemaker on the patient with sinus brady if they're having symptoms, and we can pace that heart externally before we get a permanent pacemaker form. So those are two different things we can do. So one, they're all basically buying time to get the right treatment for the patient. Here's a temporary transvenous pacemaker. You basically plug it, you put electrodes on the patient and, dial in the heartbeats per minute and other things like that. So a permanent pacemaker, though, basically we could use for sinus brady, we could use for heart blocks. They actually insert the pacer wires, they implant this under the skin, usually left side, right under the skin, above the heart, and the pacer wires go down through the vena cava right into the atria. So if they want to atrial pace and pace the atria, then they will put that implanted wire right in the atria. If they need to pace the ventricle because of ventricular problems like too many premature contractions, then they would put that wire right in the ventricle. So those are right in the chambers of the heart. Here's another picture. Here's a single chamber pacemaker. Here's your pacemaker. It goes right down into the vena cava and it gets implanted right there in the ventricle, in the chamber inside. Here's an EKG X-ray. Notice the pacer right there. This is dual paced. Here's one pacer wire, and here's the other pacer wire. So pacemakers, if somebody is paced and it's working and it's capturing and it's actually doing the job, if we did a 12 lead on someone with a pacemaker, we would have what's called pacer spikes. These pacer spikes show up as an electrical marking on your EKG. So right before your P wave, if it is a singular atrial pace, or right before the QRS, if it's ventricular pace, you would have this mark, and those are called pacer spikes. So on this example right here, this patient is V paced. Notice you have a pacer spike just before your QRS. Now, remember, if an electrical impulse originates in the ventricle, it would be wide. That's where these originate, so it's a very wide QRS. And you see here, you have a pacer spike, pacer spike, pacer spike before each QRS, meaning the pacemaker is initiating that electrical impulse. Here is an example of a patient that is dual paced. So the atria is number 1, or atrial is A, and the ventricular pace is B. Notice here's a pacer spike, here's your P wave, then we have a ventricular spike, here's your QRS. So for every one of these, we have pacer spike, it causes it to contract, there's the P wave, here's the ventricular spike, causes the wide QRS. All along here, we can see the pacemakers doing the pacing. These are then atria and ventricular pacer spikes. Sinus tachycardia. If the heartbeat is sinus, it's the normal pathway, but it's above 100 beats per minute, check the patient. Sometimes patients get very anxious if their heartbeat is too fast. If they already have cardiac disease, they could have pain because they're not getting enough oxygenated blood. Maybe they need oxygen. Maybe they need an anti-anxiety medication. A couple medications, calcium channel blockers, ones such as verapamil and beta blocker. Those are the meds that end in OLOL. Those kind of medications will slow down your heart rate. So that would help for a patient who keeps going into sinus tachycardia, for example. Atrial flutter. We're going to check the patient again, like the others. Is the patient tolerating the symptoms? What kind of symptoms are they having? Sometimes atrial flutter can be controlled by digitalis or diltiazem. That's a common thing. We can take the patient to EP lab and try to kill the cells that are causing the atrial flutter. If we need to synchronize and convert the patient, it's the same as shocking, but it's not the same as defibrillation. So remember, if someone needs to be defibrillated, that's using the same machine, but it's different than cardioversion, not cardioconversion, sorry. Synchronized cardioversion is using a lot less power. We do that at 50 joules or 100 joules for atrial flutter, for cardioversion. If we're doing defibrillation, we're starting at much higher, a minimum of 100, maybe starting at 100 or 200. Heparin. Lots of patients, most patients, if they can live with atrial flutter, meaning it's going to be chronic and they can live with this, they don't have any symptoms, they're fine. They probably need to be on Coumadin for the rest of their life. Heparin in the hospital, Coumadin when they go home, or give themselves Lovenox shots. If the atria is just sitting there and fluttering and not doing the job and moving fast, but blood's not going through, that blood just swirls in the atria and it can cause a clot. And then when the blood moves through the heart, to the ventricles, to the aorta, it could easily go to the carotid arteries, to the brain, and cause a stroke. So these patients need to be on Coumadin, most likely, or Lovenox. Now, I have met some patients that are atrial flutter or an AFib and they're not on Coumadin. Why? Well, maybe it's not near a fast a beat and their risk for causing blood clots is really, really low. Atrial fib, same as atrial flutter. Check the patient, check the leads. They have a risk of clots. Coumadin, heparin, Lovenox. Digitalis will slow down that atrial fibrillation. Amiodarone and Pronestel, those are 3 drugs that will also slow down the atrial fibrillation to possibly they will not have any symptoms. So if a patient has a very fast atrial fibrillated beat, put them on these medications, and maybe that atrial beat is now 90 beats per minute instead of 180, and they can live with that. They can be on these medications to take care of that rhythm. We could also synchronize cardiovert the patient only if it's new onset. We only cardiovert patients that have new onset atrial flutter or atrial fibrillation. If they've had it chronically, cardioversion will not help. And the patient probably knows that because they probably tried that when they were initially diagnosed with AFib or a flutter. We can take them to the EP lab. We can find the cells that are causing that and hopefully kill them, and we can then they will not go into atrial fibrillation as well.